All right, shall we continue? All right. So moving on the theme of metabolic acidosis, now we're going to go on and talk about non-anion gap metabolic acidosis. So this is often also called hyperchloremic metabolic acidosis. So instead of the bicarb getting low and the chloride staying normal, the chloride actually gets high and compensates for it so that your anion gap becomes normal. The two most common causes by far are obviously lower GI bicarbonate loss, so diarrhea or lower GI fistulas, and renal tubular acidosis. But you can get the exact same presentation in a dilutional acidosis. So patients who are getting chloride-rich fluids like normal saline will dilute down their serum bicarbonate while maintaining their chloride and cause what is essentially a non-gap acidosis. This is becoming less common nowadays as more people, even on the medicine services, are using Ringer's solution and other so-called balanced salt solutions. Urinary diversion, I think I have a slide talking about that. And then one other thing that's worth remembering is that when a patient has a primary respiratory alkalosis and compensates by lowering the serum bicarb, the anion gap doesn't change. So if you just look at the serum chemistries and see a low bicarb and a normal gap before you assume that it's a primary metabolic acidosis, check to make sure it's not just simply compensation for a primary respiratory alkalosis. Okay, so why does non-gap acidosis occur? So here's a reasonably simple example to explain this, which is the case of a patient with diarrhea. So in diarrhea, the majority of ions that are being lost are sodium and bicarbonate. So what happens is that in the blood, patient's sodium and bicarb decrease by essentially the same amount or close to the same amount. In addition to that, we often replete these patients with saline. So assuming we're not repleting the bicarb, so that might, and the kidney is attempting to retain sodium and chloride. So the sodium and the chloride might come up. But regardless, the anion gap doesn't change. So ultimately, if you have a normal sodium, the chloride would go up the same amount as the bicarb would go down, which is all another way of saying that regardless of how you mess with these electrolytes, you're never introducing another unmeasured anion, and that's why the gap never changes. Proximal RTA works the same way, but here the bicarb is just being excreted in the urine. When we're trying to determine the cause of a non-gap acidosis, oftentimes what we're trying to determine is whether someone has it due to diarrhea, either overt diarrhea or surreptitious laxative use, and renal tubular acidosis. So I'm going to talk a little bit about how we diagnose renal tubular acidosis, which I think is actually a lot simpler than people think. I think in a lot of textbooks it's made to be very complicated. I usually start by looking at the urine anion gap, not at the urine pH, and I'll explain why in a moment. So the urine anion gap is calculated differently from the serum anion gap. It's sodium plus potassium minus chloride. Why? Because the concentration of potassium in the urine can be very high and it's very variable, so you have to include that. And generally, unless the urine is very alkaline, there's no bicarb in the urine. So sodium plus potassium minus chloride is what we conventionally use as the urine anion gap. There's no real normal range. In normal people, it depends on the diet. And how does this work? So just like the serum anion gap, it's dependent on the principle of electroneutrality, that the anions and the cations in any body fluid have to be exactly equal. So that means the measured anions and the unmeasured anions have to equal the total of the measured cations plus the unmeasured cations. And if you rearrange that equation, you get measured cations minus measured anions, that's our anion gap, equals the difference between the unmeasured anions and unmeasured cations in the urine. And what are these unmeasured anions and unmeasured cations? Unmeasured anions, sulfate, phosphate, bicarbonate, organic anions. Unmeasured cations, calcium, magnesium, ammonium. But of these, most of them don't contribute a huge amount and are not terribly variable. The only two that are very variable, particularly with acid-base disturbances, are of course bicarb and ammonium. So how the urine anion gap is used is this. In the setting of a patient that is acidemic, the urine bicarbonate should be 0, should be negligible, and the urine ammonium should be high. That's how the kidney compensates for acidemia, by increasing ammonium excretion. And so if your bicarb is low and your ammonium is high, your urine anion gap should be low. How low? So here's a study from Daniel Battier that looked at this, published, 30 years ago now. So on the x-axis is the urine anion gap, and the y-axis is ammonium excretion. So here we directly measured ammonium in the urine, something that we can't easily do clinically. And what you see is that there is a negative relationship. The higher the ammonium excretion, the lower the urine anion gap, and vice versa. Okay, that's pretty good. If you compare a patient with diarrhea with a patient with, for example, distal RTA, the patients with diarrhea have higher ammonium excretion. In other words, they're able to increase renal ammonium excretion to attempt to compensate for the acidemia. Distal RTA, they cannot. So it turns out that that cutoff is maybe around 20-25 milliequivalents per liter of ammonium. But this cutoff also translates to a cutoff in the urine anion gap that just by coincidence is 0, just coincidental. So it gives us a nice thing that we can memorize, which is when the urine anion gap is negative, appropriate, then patients have diarrhea, and if the urine anion gap is positive, inappropriate in the setting of acidemia, those patients have a distal RTA. So here's a little small print stuff. If you're curious as to why we don't use urine pH, so here's one reason. There are actually many reasons, but here's a reason why we don't use urine pH to distinguish diarrhea from RTA. And so this is also from this paper from 30 years ago in the New England Journal, where Battier showed that even in patients with diarrhea, they can have alkaline urine, inappropriately alkaline urine. pH here is high as 6.5. But notice that that only occurs in those patients that have a very low urine sodium. So in patients who are very, very dry, and reabsorbing every last bits of sodium from the renal tubule, there's so little sodium delivered to the collecting duct that there isn't enough to be reabsorbed in exchange for hydrogen ion secretion. And those patients have an alkaline urine. So the urine pH is misleading. The urine anion gap is a nice indicator of diarrhea versus RTA. Okay. So simple diagnostic tests: urine anion gap, negative diarrhea, positive RTA. Another exception, again, small print stuff, not likely to come up in the boards, is that you can also get the positive urine anion gaps due to other added urinary anions. For example, patients with ketoacidosis, as I mentioned, your beta-hydroxybutyrate and acetoacetate can get excreted in the urine and increase the urine anion gap. Same for hippurate in the patient with toluene abuse. I don't really have time to go into this, but one of the proposed ways to account for this is, instead of using the urine anion gap, to instead use the urine osmolar gap. And because beta-hydroxybutyrate and acetoacetate don't really contribute significant osmoles, this is another way to estimate ammonium excretion. And if you decide you want to go that route, I don't personally use this, but it's occasionally useful. Urine osmolar gap of less than 150 indicates inadequate ammonium excretion, as in an RTA. Okay. All right, so let's assume that you've determined that the patient has a renal tubular acidosis. How do we distinguish between the types? It seems like if you look in the literature, there's a huge number of different types of RTA, but really, for all practical purposes, there are just three, okay? There's proximal, which is type 2, and two types of distal. Classic distal, which is type 1, and then hyperkalemic distal. This is the one that's often divided into many different subsets, not really clinically that important. So I'm going to lump together hyperkalemic distal and type 4 RTA and consider them essentially synonymous. So to understand how this works, it's useful to understand how acid is handled in the renal tubule. So I'm going to give you the really simplistic version of this. So the important thing to remember is that most individuals on an average, certainly American diet that are not vegans, generate net acid that needs to be excreted every day. Generally, about a milliequivalent per kilo per day of acid needs to be excreted. But before you can excrete it, as soon as you get past the glomerular filter, you filtered massive amounts of bicarb, right? So your blood has a bicarb concentration of 20 or something like that, and the filtrate's going to have a concentration of bicarb of 20. So first we have to stem the tide of bicarb loss before we can even remove net acid. And so the role of the proximal tubule is to reclaim as much of that filtered bicarb as possible. Once you've rid the filtrate, the tubular fluid of bicarb, now you can start secreting acid into it. So in the distal tubule, mainly the collecting duct, hydrogen ions are secreted by the proton pump. But if you just secreted protons into a plain urine, you wouldn't get very far, right? So if you lowered the urine pH down to 5, that's 10 to the minus 5 millimoles per liter of acid, which is 0.05 millimolar, so a tiny amount. So free acid doesn't really get rid of enough acid from the body. So the trick is that we also have a buffer, ammonia. And so ammonia acts essentially like a carrier or a sponge to soak up all these hydrogen ions and then get rid of large amounts of it as ammonium in the urine. So those three steps are needed for acid excretion. Reabsorb all the bicarb, secrete the protons, and then buffer them and get rid of them as ammonium. So this gives us the three main things that go wrong in RTA. Proximal RTA is pretty simple. You can't reabsorb bicarb, so you get a profound bicarbonaturia. Type 1, or classic distal, is a problem of hydrogen ion secretion. You can't secrete hydrogen ions, so you can't even lower the urine pH. And type 4 and hyperkalemic distal RTAs, the main problem is that you can't generate enough ammonia to act as a sponge and soak up these hydrogen ions and get rid of it. So even though you can secrete hydrogen ions and lower the urine pH, you can't get rid of enough net acid. So this gives rise to the clinical features of RTA that help you to distinguish between them. So the serum potassium, as I mentioned, is low in all of these conditions except hyperkalemic type 4. So that's pretty easy. The urine anion gap is positive in a distal RTA and negative in a diarrhea. Proximal RTA is complicated, so I put variable here, and we'll get to why it's complicated in a second. And this is often a cause of great confusion. Urine pH is greater than 5.5 in a type 1 distal RTA. So the major problem in a type 1 distal RTA is the inability to secrete protons, so the urine pH is always high. Type 4 is characterized by a low urine pH. In other words, they're perfectly able to secrete hydrogen ions into the urine, they just don't have enough buffer to get rid of it. So the pH is appropriately low, but the urine anion gap is high. Diarrhea, as I mentioned, the urine pH can be variable, so that's sometimes confusing. Proximal RTA also variable. And then there are other features that help you to that are clues to this. So, for example, virtually all adult patients, I'm going to go out on a limb here and someone will tell me I'm wrong, but virtually all patients, adult patients with proximal RTA, have a generalized proximal tubular disorder, in other words, a Fanconi syndrome. And certainly all of the board questions I've seen on this, they've had patients that had Fanconi syndrome. It would be really mean to present a patient with just an isolated proximal RTA. So looking for features of Fanconi's is a really good clue to whether a patient has a proximal RTA. Similarly, classic or type 1 distal RTA, these patients often have nephrocalcinosis, they're hypocitroturic, and sometimes they have calcium phosphate kidney stones as well. So what about proximal RTA, and do you really need to know all this? So this is sort of small print stuff. It's useful to be aware of this. It's also in the textbooks, but for adult nephrologists, we don't really spend much time trying to figure out whether someone has a proximal RTA. It's just not a huge clinical problem. In kids, it often is. So the issue here is that in a proximal RTA, the problem is that the capacity to reabsorb bicarb has been lowered, but it's not generally zero. The capacity in the proximal tubule has been lowered. So there's a threshold amount of bicarb that's filtered that can be reabsorbed by the proximal tubule. If you raise the bicarb above that level, then they can't reabsorb it and they start spilling bicarb in the urine. Okay, so on the left here would be what you might think an untreated proximal RTA is. The bicarb perhaps is down at 17 or 18. They don't have much bicarb in the filtrate, again, about 17 or 18. And it's possible that that's all completely reabsorbed in the proximal tubule, and therefore urine bicarbonate, if you were to measure it, would be undetectable. Urine pH, if you were to measure it, would be appropriately low, and the urine anion gap would be negative. So this patient would be compensated, albeit sitting at a low bicarb. And so this gives rise to this common aphorism that the bicarb in proximal RTAs gets to a certain point and then doesn't go any lower. It's very unusual to see a proximal RTA with a bicarb of 11 or 12. It usually stops at about 17. Now, if, for example, you were to treat this patient by giving the patient sodium bicarbonate or sodium citrate and attempt to force that serum bicarbonate up, now they start filtering more bicarbonate. It exceeds the threshold for reabsorption by the proximal tubule. They spill it in the urine, and they have an alkaline urine and a very positive anion gap. So depending on where you are on this spectrum, your pH in the urine can be low or high, and your urine anion gap can be negative or positive. But as I said, the clue to the proximal RTA isn't to do all of this. The clue is to look for features of Fanconi syndrome, which include glycosuria despite normal glycemia, hypokalemia, generalized amino aciduria, urinary phosphate wasting, and hypouricemia. In terms of common causes of renal tubular acidosis, proximal RTAs, nowadays we see most of these from plasma cell dyscrasias, either frank myeloma or amyloid or light chain deposition disease. Certain drugs like ifosfamide do it, as do certain types of reverse transcriptase inhibitor antivirals like tenofovir and adefovir. Down here are things that we hardly ever see in adult patients: heavy metal poisoning, cystinosis, and Wilson's disease, common causes that are when they present as kids. Type 1 RTA is classically caused by an autoimmune disease, either Sjogren's or lupus. We see this with cirrhosis. A very similar picture is seen in amphotericin and patients with this congenital but not inherited disorder, otherwise benign, called medullary sponge kidney, can also have the same picture. And then type 4, which is can be due to hyporeninemic hypoaldosteronism, as in patients with diabetes and mild CKD can be caused by a bunch of tubulointerstitial diseases. Let me rephrase that. Kidney diseases that have a propensity for affecting the tubulointerstitium, like sickle, lupus, obstructive uropathy, sometimes HIV. And then remember, any drugs that act on the renin-angiotensin-aldosterone system would cause a similar picture. So ACE inhibitors, ARBs, NSAIDs, CNIs, and heparin. And the important thing about all of these is that the acidosis is relatively mild and usually not a major clinical problem, whereas the major clinical problem is almost always the hyperkalemia. And this is just to remind us of the effect of adefovir, cidofovir, and TDF, tenofovir diproxyl fumarate. I don't know what the incidence of this is with the newer version of tenofovir that doesn't get transported in the proximal tubule. But these older versions are all transported by the organic anion transporter OAT1. And so they get in the proximal tubule. They're mitochondrial toxins. And so they inhibit the ability of the proximal tubule to generate energy and reabsorb solutes. And they cause both Fanconi's and, of course, ATN. Some of them can be made worse by drug interactions or by renal insufficiency. In terms of treatment of RTAs, so type 1 and proximal RTA, the major treatment is to correct the acidosis. In adults, the major issue is concern over chronic bone loss and type 1 RTA kidney stones. In children, failure to adequately correct acidosis is a big problem for their normal growth. And so the major difference between this is in a type 1 RTA, the problem is the failure of the kidney to excrete your normal acid daily acid load. That's about 1 milliequivalent per kilo per day. So you really only need to give patients around 1 milliequivalent per kilo per day of base, either as bicarb or citrate, usually of potassium because they're hyperkalemic. And I prefer citrate because then you also increase the citrate in the urine, which inhibits the kidney stone formation. And proximal RTA, it's a lot harder because they're having a bicarb spilling problem. And as we discussed, the higher you raise the serum bicarb, the more bicarb spills into the urine. So oftentimes you need much higher doses of bicarb to correct it, certainly more than 4 and sometimes as high as 10 milliequivalents per kilo per day. In type 4 RTA, as we discussed, acidosis is usually not the major problem, and most of the problem is trying to control the hyperkalemia with all our usual suspects. Moving away from RTAs, a word or two about urinary diversions. As many of you are aware, urinary diversions that are formed in patients who have bladder surgery from intestinal segments can cause a metabolic acidosis. And the reason for that is that the intestinal wall doesn't handle acid the same way as the bladder, which is essentially impermeable. Most of these patients have conduits or even continent pouches that are made from parts of the ileum. And the ileum reabsorbs ammonium with chloride. And so these patients can present with a normal anion gap acidosis with a positive urine anion gap that is essentially indistinguishable from a distal RTA. So these patients can have a chronic metabolic acidosis and then come into hospital with an acute exacerbation. And when they have an acute exacerbation, it's important to look for obstruction of their conduit or their continent pouch because that's usually the cause that the urine sits in the conduit for too long, and so there's excessive absorption of ammonium that wouldn't normally occur. Dilutional acidosis, I think we already talked about, so I'm not going to go into that. Finally, a word about treatment. So in a non-GAP acidosis, giving bicarbonate and correcting the acidosis is logical, and everyone accepts that. In an anion-GAP acidosis, there's some concern about treating so-called endogenous organic acidoses like lactic acidosis and DKA. And there are a couple of concerns with that. One is that the organic anions, particularly in DKA, will eventually, if you correct the underlying cause, get metabolized back to bicarb. Also, when you give bicarb to a patient who's acidotic, hydrogen ions titrate the bicarb and generate CO2, something which is permeable across cell membranes. So in patients that have reduced perfusion, so for example, a patient with shock, tissue CO2 levels can rise dramatically. The CO2 enters the cell and causes paradoxical intracellular acidosis. So, for example, in the heart, cardiac function might potentially actually get worse with bicarb therapy. And then there are obviously complications that we are all aware of with bicarb drips, like hyponatremia, hypokalemia, and alkalemia. Exactly what pH one should give bicarb for in these conditions is quite controversial. What I'll say is that being a nephrologist, we generally have a lower threshold for treating these patients if they have decreased GFR, because the lower your GFR is, the more rapidly your pH drops when you generate acid, so because of the inability to excrete some of the acid. If you want to calculate the amount of bicarb to give, something that I don't routinely do but occasionally do, and not something you need to do for the boards, I don't think, this is how you do it. So first you have to calculate the volume of distribution of bicarb, which we call the bicarbonate space. So you would think this would just be the total body water, but it isn't, because remember that acids are buffered not only by bicarb in the extracellular fluid, but also intracellularly. And the more acidotic you get, the more buffering occurs inside the cells. So if you imagine someone with a bicarb of 3 or 4, which sometimes occurs, you can't really lower the bicarb any further. So where does all that acid go? It goes into the cells. So the bicarb volume of distribution of bicarb actually increases as your bicarb goes down. So you calculate that and then plug this into this formula, bicarb space times the delta concentration of bicarb, and that tells you how much bicarb you need to give a patient. So this was one paper which is a randomized trial where patients were given bicarb or no bicarb to maintain a pH of greater than 7.3 with a primary composite outcome of death or at least one organ failure at day 7, published last year in The Lancet. And you can see that wasn't really any significant difference, certainly in the probability of survival, but there was a difference in the incidence of acute kidney injury that favored those that got aggressive bicarb therapy for the severe acute kidney injury. And this was the cumulative use of renal replacement therapy. Not surprisingly, the patients who didn't get the control group eventually needed more replacement therapy. Okay, so the controversy lives on. So in the last 15 minutes or so, we'll talk a little bit about metabolic alkalosis. Some of this overlaps a lot with the discussion of hypokalemia, because many patients have both. So should not take too long. So when I see a patient with metabolic alkalosis, the first question is, what induced the metabolic alkalosis? And there are essentially 3 possibilities. Either they ingested something that was alkaline, or they lost an acid, which has to be either through the GI tract or the kidney, or there's cellular shift where hydrogen ions have entered the cell. Not usually a major contributor, I should add. So what alkalis can one get in? So antacids obviously have alkali in them, and then the other major source not ingestion, but infusion, would be blood products that have a lot of citrate in them, especially if you have massive transfusions. What about, antacids obviously on their own don't generally cause alkalemia, but they can in two situations. One in patients with significant renal insufficiency, and the second is in patients who get calcium with it and develop this condition of milk alkali syndrome, which some people now say should be called calcium alkali syndrome. So this refers to the combination of metabolic alkalosis, hypocalcemia, and AKI. It now accounts for nearly 12% of hospitalized patients with hypocalcemia, so it's pretty common, and it's due to the increased use of calcium carbonate nowadays. And the pathogenesis is as follows. So patients have to get an antacid that has calcium, so it's both an alkali load and a calcium load. This causes a two-armed, pronged response, if you will. So alkalosis actually increases calcium reabsorption in the distal convoluted tubule and decreases calcium excretion. So any calcium that's being ingested is actually being conserved rather than being excreted. And conversely, calcium itself, through its action, we think, in the calcium sensing receptor in the thick limb, actually increases collecting duct hydrogen ion secretion, and therefore worsens any alkalosis. And then on top of that, hypocalcemia, as you know, directly vasoconstricts and indirectly precipitates in the kidney to cause acute kidney injury. And to the extent that your GFR is decreased by that, and also, I should add, causes natriuresis and volume depletion. And so volume depletion and acute kidney injury also worsen bicarb conservation and decrease bicarb excretion. So these three synergistic processes all act together in what we might describe as a perfect storm, and then patients present with a hypercalcemia, severe alkalosis, and often acute kidney injury. Okay, so on to loss of acid. So GI loss of acid, that's fairly obvious. You can get it from vomiting. You can get it from persistent nasogastric suction. You can also get metabolic alkalosis from lower GI losses, but not conventional diarrhea, because in conventional diarrhea, you're losing mostly bicarbonate. But if you have a diarrhea that's mostly chloride, a chloride-rich diarrhea, that can cause a metabolic alkalosis. And so, for example, some patients with villous adenomas will present that way. Sometimes chronic laxative abusers can present that way. Renal loss of acid. So aldosterone normally acts to reabsorb sodium in the collecting duct in exchange for secretion of acid and potassium. So you can get metabolic alkalosis if you deliver more sodium to the collecting duct, either because you have an inherited defect in the ability to reabsorb sodium in the thick limb or the DCT, or you give a diuretic that inhibits that. So all of these cause hypokalemic metabolic alkalosis. You can also get this if your aldosterone levels are too high, or you have one of those conditions that mimics high aldosterone. And then you can get something similar, in this case, due to what's a persistence of a normal renal response to respiratory acidosis, which is called post-hypercapnic alkalosis. So this again explains how these renal acid loss works. I'm not going to go into this in any detail. Okay, so this is again to remind you of the differential diagnosis for hyperaldosteronism. So if you see a patient with hypokalemia, metabolic alkalosis, and hypertension, these are the common causes, distinguished by whether their renins and aldos are high or low. These are the rarer causes. And these are the tests that you can do to distinguish between them. Some of them are fairly obvious. Renal artery stenosis, you might want to do a Doppler ultrasound or MRI. Primary aldo, hyperaldo, we usually start screening with an aldo to renin ratio and then go on to a confirmatory test that includes salt loading and either measurements of the aldo in the blood or 24-hour urine. GRA, I mentioned before, you look at urine 18-oxo and hydroxycortisol, which are abnormal metabolites generated because the aldosterone is being made in the part of the adrenal gland that normally makes glucocorticoids. Licorice syndrome of apparent mineralocorticoid excess are conditions where the enzyme that normally metabolizes cortisol to cortisone is inhibited or mutated. So urine-free cortisol to cortisone ratios are elevated. Little syndrome, if you really want to diagnose it, you'd really need to send ENaC mutation analysis, and Cushing's, you would measure cortisol levels. Post-hypocapnic alkalosis refers to patients that have chronic respiratory acidosis, so COPDers or patients of Pickwickian, for example, who have appropriate normal compensatory renal bicarb retention. Okay, so this is a way of preventing very severe acidemia. If they come into hospital with severe respiratory acidosis and start on mechanical ventilation, one can restore the PCO2 very, very quickly. But the serum bicarbonate would remain high, and so the pH would become very high. And the patient would behave as if they have a primary metabolic alkalosis. Now, the important thing here is that we all assume that this is going to resolve over time. And it resolves over time because in the absence of this stimulus to bicarb retention, the kidney would excrete the bicarb. But it can only excrete it if all of these three things are true. There's sufficient time given, usually a matter of days. There's got to be adequate renal function. Patients with low GFR can't do this. And most importantly, and probably the most common issue, they have to be euvolemic. Patients who are volume depleted are unable to excrete their bicarb. And we'll get to why in a second. And then this is just to remind you that if your patient is hypokalemic, that can cause a metabolic alkalosis due to cellular shift, but this is a very, very small effect and not usually a primary cause of an alkalosis. The other thing that does happen is that if a patient has hypokalemia, this increases the HK-ATPase in the medullary collecting duct. So this is a pump that reabsorbs K in exchange for hydrogen secretion, and that would also worsen metabolic alkalosis. And then finally, one other cause that we don't normally consider in this algorithm is contraction alkalosis, which some people have suggested should be called chloride depletion alkalosis. So contraction refers to a contraction in the extracellular volume of the patient, but essentially it's contraction due to loss of chloride-rich fluids and water in excess of bicarbonate, okay? And then when that occurs, your bicarbonate concentration goes up, but it only causes an alkalosis if the kidney can't excrete the bicarb. So it turns out that, as I mentioned, in patients who are volume contracted, a couple of mechanisms are in play that prevent you from excreting bicarb. So one is that when you're volume depleted, you're trying to conserve sodium. So the renal tubule tries to reabsorb sodium, and it does so with bicarbonate. A second, which I don't have here, is that your aldo levels get high, and that causes, again, reabsorption of sodium. It's considered a good thing, but in the collecting duct in exchange for hydrogen ion secretion. And then the third is that you downregulate a mechanism for bicarbonate excretion, which is pendrin, which normally does chloride bicarbonate exchange. And so that decreases another method for getting rid of bicarb. So of all of these causes of induction of metabolic alkalosis, they would all not cause significant alkalosis if it were not for some way of maintaining alkalosis. The kidney normally can restore alkalosis pretty well unless patients are also volume contracted, as we mentioned. So vomiting can cause an alkalosis, but it's very minimal until patients get significantly volume contracted. Hyperaldosteronism, as we mentioned, hypokalemia, and then, of course, renal failure. Patients have a low GFR. They simply can't get rid of bicarb. This shows what happens to your urine lights after vomiting as an example. So this is not something you need to remember, but I think it's quite instructive. Early on, when a patient starts vomiting, the kidney tries to get rid of bicarb to correct the pH. So the urine sodium would be high, the urine bicarb would be high, and the pH of the urine would be alkaline. Seems appropriate. Late on in vomiting, so it's an attempt to get rid of excess alkali. Late on in vomiting, when patients start to get quite volume depleted, the kidney starts focusing on conserving sodium in the face of severe volume contraction. And the proximal tubule, that sodium is reabsorbed with bicarb. And so urine sodium and bicarb now are low, and the urine pH, rather than being alkaline, is acidic, less than 5.5. And that's been termed paradoxical aciduria. It's an inappropriately acid urine in the face of an alkalemic patient. So what you can see, so the important thing here is that the urine sodium can be high or low in a metabolic alkalosis. But note this, the urine chloride is always low in these patients that are losing bicarbonate. And so the urine chloride is a really good clue to whether the patient has a metabolic alkalosis due to loss of bicarb-rich fluids. And so this gives rise to this quite useful algorithm for diagnosing a patient with what I've called a cryptogenic hypokalemic metabolic alkalosis. So 90% of the time when you have a patient with this, you know the diagnosis. They're vomiting. It's really not a mystery. But if you can't figure out what they have, then these are the 4 possible causes. So one is hyperaldosteronism. That's obvious because this is the only diagnosis where patients are hypertensive. All of these other cases, patients are normotensive and usually volume depleted. Surreptitious vomiting, surreptitious diuretic abuse, or an undiagnosed case of Barter's or Gittleman's. And the urine chloride here is critical. It's low in surreptitious vomiting. So this is, if you think of it simplistically, a surrogate marker of extrarenal volume depletion, less than 25. Your urine chloride is high, which means greater than 40, then they're having renal salt wasting as the cause of the metabolic alkalosis. Differentiating between diuretic abuse and Gittleman's, not so easy. If you're lucky and you assay the urine when they're taking the diuretic, you can uncover a case. But sometimes they stop taking the diuretics before they come to see you. So if you look at the urine sodium and chloride, patients with diuretic abuse can have urine chlorides that are high or low and vary considerably depending on where they are in their cycle of taking diuretics. Barter's and Gittleman's, the urine chloride is persistently high and the urine diuretic screen is persistently negative. In terms of treatment of metabolic alkalosis, obviously you want to treat the underlying cause. A really critical thing is to correct extracellular volume depletion. In many of these cases, if you just restore volume to normal, they are able to excrete their bicarb themselves. And you want to correct them with chloride-rich fluids and also to correct K depletion because hypokalemia also causes maintenance of alkalosis. Acetazolamide is sometimes useful for increasing bicarb excretion if you have adequate renal function. So this is a good one to use in patients in edematous states. You can always dialyze a patient, and if all else fails and you can't dialyze, you can try and give them acid like dilute hydrochloric acid or arginine hydrochloride. Here's some suggested additional reading. Thank you for your patience.